Welcome to this peer voice activity. To access the entire activity, including supporting material, go to www.peervoice.com/pxk. This activity is supported by an independent medical education grant from Madrigal Pharmaceuticals.
Hello, I am Dr. Javier Ampuero from Hospital Universitario Virgen del Rocío in Sevilla, Spain. I am delighted to welcome Dr. Mina Bansal from Mount Sinai Hospital in New York, USA. Over the next 20 minutes, we are going to focus on the subject of MASH in the gastroenterology clinic. We have one new treatment recently approved in Europe and another on the way. These new options, together with the usefulness of non-invasive tests for assessing MASH, mean that gastroenterologists can take ownership of its management without necessarily involving the pathologist. But first, we are going to look at why it's so important to be on the lookout for possible MASH in your patients. During the last years, the name of the liver disease related to the deposit of fat has changed from NAFLD, non-alcoholic fatty liver disease, to steatotic liver disease. The steatotic liver disease is an umbrella term that it includes patients with MASLD, metabolic dysfunction-associated steatotic liver disease, to patients with a specific etiology such as Wilson's disease and drug-induced liver injury. If we look into the definition of MASLD, it's needed to have at least one cardiometabolic risk factor, obesity or overweight, type 2 diabetes or prediabetes, hypertriglyceridemia, or arterial hypertension, in the absence of a relevant alcohol consumption defined by a threshold of 20 and 30 grams per day in women and in men. So, Dr. Bansal, how have these changes affected you as a clinician and in your interactions with your patients? And if you identify some gray area in this new nomenclature, because, for instance, it's difficult sometimes in clinical practice to do a correct assessment of the alcohol intake because we don't have PET widely available in Spain and in other countries.
Yeah, I think one of the biggest advantages of this nomenclature was kind of giving a name to MET-ALD with the recognition that people with metabolic risk factors drink more than they tell us. And on the other hand, those with alcohol-associated liver disease also have metabolic risk factors. So I think what this has changed for us is being very clear about asking about alcohol. Of course, people might not be fully forthcoming, but we do use PET. And we use it in everybody so that there's no kind of implicit bias there. Just check the path and use that to educate your patients and to work with them managing how they're, the causes of their liver disease.
Steatotic liver disease is the most common liver disease worldwide. In fact, up to 25% of the overall population has MASLD. And the challenge is the predictive prevalence of MASLD. MASLD is strongly associated with diabetes and obesity, and the prevalence of them is increasing over time. So the prevalence of MASLD is increasing as well. The predicted prevalence of MASLD in 2050 is about 40-45%. But MASLD is more common in some specific patient populations, particularly in patients with overweight or obesity and patients with type 2 diabetes. In the case of patients with overweight or obesity, the prevalence of MASLD is about 70%, and up to 1/3 of them has steatohepatitis, which is the active form of the liver disease, which requires inflammation and ballooning. But of note, about 40% of patients with MASLD are non-obese and up to 20% are lean. The situation is similar for patients with type 2 diabetes because the prevalence of MASLD is about 65-70%, and up to 30% of them has steatohepatitis. Of note, in diabetic clinics in specialized units in patients with diabetes, the prevalence of significant and advanced fibrosis is about 35%. In addition to this, there are other conditions which are associated with muscle D, even in the absence of metabolic components. For instance, the presence of immune-mediated disease, including Crohn's disease, ulcerative colitis, or psoriasis, are associated with a higher prevalence of muscle D, and particularly or even with advanced fibrosis. However, despite the high prevalence of muscle D, this entity is underdiagnosed in clinical practice. This fact has been demonstrated many times in real-world cohorts. So, Dr. Bansal, what's your opinion in gastroenterology clinics? We have the same problem. Muscle D is underdiagnosed in our clinics.
Absolutely. I mean, I think it depends on why they were sent to you in the first place. So I think that if they're sent for abnormal liver enzymes, gastroenterologists are likely making the diagnosis because they're doing that full workup. But if they're just being sent for, say, a screening colonoscopy, but they have metabolic risk factors, I think that's where we may be not doing the appropriate screening.
Muscle D is an entity that can progress and also regress, but if the progression exists, is associated with poor outcomes. Approximately up to 30% of patients with muscle D can progress in any way in 4 or 5 years. And there are well-known variables associated with this progression, this rapid progression in muscle D. One is the presence of MASH, the presence of steatohepatitis, either in the liver biopsy or with the presence of hypertransaminasemia in the lab parameters. Other challenging situation is the poor control of the metabolic components, particularly the poor control of diabetes or the presence of a severe obesity, or even the occurrence of some metabolic disease during the follow-up of the patient with muscle D. The occurrence of diabetes or the occurrence of arterial hypertension are also associated with the incidence of fibrosis or cirrhosis. The fibrosis stage is the main prognostic factor in liver disease and in muscle D setting as well. Patients with F2, F3, and particularly F4 are associated with a higher risk of liver-related events or liver-related outcomes, including hepatocellular carcinoma and any decompensating events, and of course, with all liver-related mortality. At the end of the day, the all-cause mortality is also related with the fibrosis stage because both cardiovascular disease and extrahepatic malignancies are as well associated with muscle D, particularly in patients with more advanced fibrosis stage. So we have established MASH is common, particularly in patients with obesity or type 2 diabetes, but it remains underdiagnosed. It can rapidly progress to poor outcomes, and fibrosis stage is a strong predictor of progression. Before we move on to look at diagnosis and treatment, please answer the following question. Dr. Bansal, thank you very much for joining me, and thank you, the audience, for watching.
Thank you. Welcome. I'm Dr. Bansal from Mount Sinai, and I have the pleasure to be joined by Dr. Amparo from Sevilla. And we're going to be focusing on MASH fibrosis, specifically the high risk of progression to poor outcomes in patients with MASH highlights the need to diagnose early and intervene promptly with effective treatments. The question is, how can you best do this in the gastroenterology clinic? We're going to take a look at the latest guidance for simple, non-invasive assessments and the evidence-based treatments that gastroenterologists can prescribe for their patients with MASH. So MASH is straightforward to assess. We know that we have at-risk populations, specifically type 2 diabetes, those with obesity and at least one cardiometabolic risk factor, or persistently elevated liver enzymes, or steatosis on imaging. all the algorithms recommend a very simple two-step process. First, calculation of FIB4, which comes from age, AST, ALT, and platelets, as really the first line of defense. If that FIB4 is less than 1.3, they're low risk, but certainly they can become high risk, so you want to reassess that every 1 to 3 years. If that FIB4 is greater than 2.67, patients should go directly to gastroenterology or hepatology. However, if they're in this intermediate or gray zone of 1.3 to 2.67, you need something else, whether that be a VCTE to estimate liver stiffness or some blood-based biomarkers, and we'll get into that. Keep in mind that since age is part of the FIB4, the threshold for those over 65 increases to 2.0. So we mentioned that there's a number of non-invasive tests that are already out there. For steatosis on FibroScan, there's something called a control attenuation parameter, and that can detect down to about 10% fat. We know that the diagnosis of MASLD requires 5% steatosis, and really with MRI PDFF, you can get down to that 5%, but it's expensive and often not available. In terms of non-invasive tests for fibrosis, we have the blood-based biomarkers that I mentioned, FIB4 already, but then the ELF test is now emerging as a very good second-line test if that FIB4 is in the indeterminate range. Once you do VCTE, if the KPA is less than 8, then they have low-risk fibrosis. If, however, it's greater than 8, then you want to refer them to gastroenterology or hepatology. MRE is more accurate, but certainly less available. And we know that once we diagnose these patients, fundamental to any treatment is weight loss, no matter how you achieve that, whether that be through improved diet or exercise. We know that if you lose at least 5% of your body weight, that causes steatosis reduction. 7% body weight loss results in MASH resolution. And if you can lose 10%, then that is associated with fibrosis regression. And we're going to talk a little bit about some of the now therapies that we have that these patients can get. So we now have resmetirom, which is an oral thyroid hormone beta agonist, originally approved in the U.S. in 2024 and received EMA approval more recently. This is for patients with F2, F3 fibrosis, and essentially it is a liver-targeted drug which improves the beta oxidation capacity of hepatocytes, essentially burning the fat. It also increases LDL receptors on the hepatocyte, so also causes a decrease in atherogenic lipids like ApoB, LDL, as well as Lp(a). Now, I think many of you may have more experience with GLP-1 since they've been on the market for both diabetes and obesity, but we anticipate approval for MASH in the EMA this year. Keep in mind that there are no GLP-1 receptors in the liver, and so primarily works through weight reduction and improvement in insulin sensitivity. So I'm just going to quickly go over the MAESTRO-NASH phase 3 data. This is a dose of resmetirom at 80 versus 100 milligrams compared to placebo. And those on 100 milligrams had MASH resolution compared to placebo. Similarly, in terms of improvement of fibrosis stage by 1 without worsening of steatohepatitis, you can see 26% in the 100 milligram dose compared to placebo. As I mentioned, this drug also increases LDL receptors, so you see a 16% reduction in LDL. In terms of common side effects, nausea and diarrhea are the most common. They tend to occur in the first 4 weeks and resolve by 12 weeks. It rarely results in discontinuation of the drug.
Dr. Bansal, what is your experience using resmetirom in clinical practice?
Yeah, so it's a weight-based dosing. So if you're 100 kilograms or less, then you get 80 milligrams. If you're 100 kg or more, you get 100 milligrams. There's a couple of drug-drug interactions that we're mindful of. One is clopidogrel. In that case, you need to decreased by 20 milligrams. So whatever you started at, you have to go down to 20 milligrams. And there are maximum statin doses. So rosuvastatin, as an example, max dose is 20. Atorvastatin is max dose of 40. So if patients are on higher levels, we decrease the statin, and then we see how their LDL does in 6 months. As I mentioned, it itself reduces LDL. And so you can kind of see if you need anything else. We don't really check liver enzymes unless there's a concern. Most of the recommendations say you can do a check-in at 3 months, but the only time we've seen elevated liver enzymes is when patients are on a concomitant statin, but it improves with time. So we just educate the patient and the PCPs that may happen, but we reassure them to continue therapy. Now we're going to move on to the Essence Phase 3 trial, which looked at semaglutide. And this study, they hit both primary endpoints, resolution of MASH with no worsening of liver fibrosis, as well as a reduction in liver fibrosis without worsening of MASH. And you can see the delta is approximately the same as we saw with resmetirom. Now, I imagine, Dr. Impera, you guys are using semaglutide at the 2.4 milligram dose already for the management of obesity?
We are using recently this drug. Most of our patients, however, has semaglutide for obesity or type 2 diabetes. I think it is important to highlight that the dose of obesity and muscle is not the same that diabetic patients. In diabetes, semaglutide is indicated at a dose of 1.2, which is not enough for the liver, for muscle D, and we need to keep in mind this fact when we see a patient from a diabetic clinic or from other specialists, because although semaglutide can be prescribed in this patient, maybe the dose is not enough.
Wonderful. Now, having discussed all of the optimal treatments that we have, for you as gastroenterologists, you want to look at patients who might be at risk for MASH, specifically those with diabetes, obesity, and other metabolic risk factors. You first perform the FIB-4, and if they are high risk, then you want to do a secondary test like VCTE or liver stiffness. Kind of the sweet spot for treatment when you're looking for those F2, F3 patients by VCTE, that would be a KPA of about 8 to 15. Now, if patients have KPAs greater than 20, there's a good chance that they have cirrhosis. Those are patients that are not eligible for treatment at this time and should definitely be referred to liver specialist. Also, those who have clear evidence of portal hypertension, low platelet count, big spleen on ultrasound, they should be referred to hepatology, where they will be undergoing HCC screening. They may be eligible for other therapies such as carvedilol to lower portal hypertension or risk of bleeding. So I think the gastroenterologists play a key role in identifying those patients with non-cirrhotic MASH and then linking them to appropriate therapy. So I think that for our gastroenterologists that are listening today, lifestyle modification is fundamental. You want to be on the lookout for patients who may have those metabolic risk factors and simply do the screening algorithm that's been recommended by all the societies, starting with a FIB-4 followed by second level testing, whether that be VCTE or ELF. Those that have ELF greater than 9.2, those that have a VCTE greater than 8 would be potentially eligible for these new therapies. Keep in mind that neither therapy is approved for those with cirrhosis. So patients with cirrhosis should be referred to hepatology so that they can have liver cancer screening and other management. And now, please answer this challenge question. Any final thoughts, Dr. Impera?
Just a brief comment. Muscle is a high prevalence entity. We need to identify at-risk patients to apply the simple algorithm proposed by the ESL with this two-step algorithm, FIB-4 and transit elastography, and to make early interventions to avoid the rapid progression of the liver disease. So thank you, Dr. Bansal, for your participation in the program. And again, thank you, thank the viewers for watching.
This has been an activity published by Peer Voice.